Chapter 33, the urinary system. The kidneys are bean-shaped organs that are positioned on either side of the vertebral column at the level of the first lumbar vertebrae. The left kidney is slightly higher than the right kidney. The kidney consists of the cortex, which is the outer layer, the medulla, the inner layer, and the renal pelvis. The cortex contains blood vessels and nephrons, the medulla contains the collecting tubules, and the renal pelvis gathers the urine and directs it to the bladder. The bladder is a hollow muscular organ that serves as a reservoir for urine. The inner lining of the bladder is a mucous membrane. The walls of the bladder are smooth muscle, called detrusor muscle, that expand to store urine and contract to expel urine. The urine passes from the bladder down the urethra, which is approximately 3 to 5 inches long in women and 20 centimeters long in men. The internal involuntary urethral sphincter is controlled by the detrusor muscle in the wall of the bladder. The external urethral sphincter voluntarily controls the release of urine to the outside. Blood is brought to the kidney by the renal arteries that branch off the aorta. Blood is returned by the veins to the inferior vena cava. The kidneys eliminate metabolic waste by filtration. 20% of the blood flowing through the glomerulus is filtered at any given time. Each nephron filters blood plasma through the semi-permeable glomerular membrane. The glomerular filtration rate is the amount of blood filtered by the glomerula at any given time. The average filtration rate is 125 milliliters per minute. Most of the water and some of the electrolytes are reabsorbed into the bloodstream in the descending and the distal convoluted tubules. The kidney assists in maintaining acid-base balance by secreting hydrogen ions into the urine. Unwanted substances, urea, creatinine, and uric acid are retained in the tubules with some water. Approximately 200 liters of liquid are filtered in a 24-hour period. 1.5 to 2 liters are excreted as urine. The kidneys regulate blood pressure by secreting the enzyme renin. The kidneys increase red blood cell production by secreting erythropoietin. The kidneys metabolize vitamin D into an active form. Each ureter is a small tube, approximately 25 centimeters long, and it carries urine from the renal pelvis to the bladder. The bladder holds the urine, and the normal capacity is 300 to 400 milliliters. The maximum capacity may reach 1,000 to 1,800 milliliters. A feeling of fullness and an initial signal to void occurs when the bladder contains 150 to 200 milliliters of urine. The micturition or voiding reflex is then initiated and transmitted to the bladder. Urine then passes from the bladder through the urethra during urination. The flow of urine is controlled by the internal urethral sphincter and the external urethral sphincter. The nephron is the functional unit of the kidney. There are 1 million nephrons in each kidney. The nephron consists of the glomerulus, which is a network of capillaries encased in a thin-walled sac called the Bowman capsule, and the tubular system. The tubular system of the nephron consists of the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. Urine is carried by the ureters from the kidney to the bladder through peristaltic action. Once the urine is formed, the urinary system must be patent and unobstructed for urine to be excreted. A healthy diet, exercise, and not smoking will also promote urinary health. The blood urea nitrogen test. Urea is produced when protein breaks down. It then combines with ammonia and is carried by the bloodstream to the kidneys for excretion. Creatinine is a byproduct of skeletal muscle contraction. The BUN and serum creatinine are interpreted together, and the laboratory values should be obtained before the use of any radiologic contrast dye. Creatinine clearance is a good measure of the glomerular filtration rate. Cystatin C is a relatively new test used to evaluate the GFR, or glomerular filtration rate. Cystatin C is a low molecular proteinase inhibitor that is produced at a constant rate and filtered out by the glomeruli. With impaired kidney function, cystatin C levels rise. The normal value of cystatin C level is 0.70 to 0.85 milligrams per milliliter. This diagnostic test shows promise of being a better indicator of the GFR than the creatinine clearance. BUN level and serum creatinine are the two most common tests that are used to screen for kidney problems. The normal adult range for BUN is 10 to 20 milligrams per deciliter. Serum creatinine is 0.6 to 1.2 milligrams per deciliter for men and 0.5 to 1.1 milligrams per deciliter for women. An increase in either the BUN or the serum creatinine can be a signal of decreased kidney function. A KUB radiography is used to locate stones and detect structural abnormalities. An angioplasty is used to open blocked vessels and increase blood flow to the organs. Urodynamic tests, such as a cystometography, are used to measure the flow volume, and muscle function. Biopsies of the kidney or bladder are done in combination with radiologic exams to locate any lesions. The BUN level and the serum creatinine are the two most common tests to screen for kidney problems. The BUN can rise from dehydration and increased protein in the blood from a high protein diet or the digestion of blood in the gastrointestinal tract with GI bleeding. To evaluate kidney function, the two values must be examined together. If the BUN is elevated and the creatinine is normal, the BUN elevation is not due to kidney problems. Anuria, absence of urine. This rarely occurs, but it could be associated with acute renal failure. Oliguria, diminished or abnormally decreased flow of urine. This may be caused by dehydration, renal failure, or obstruction. Polyuria, an abnormally high and dilute urine output, can be the result of excessive solutes and increased excretion of water, with possible causes including hypercalcemia, diabetes insipidus, uncontrolled diabetes mellitus, and increased fluid intake. Nocturia is urination that occurs during the night. and it may be related to the decreased ability of the aging kidney to concentrate urine. Urine frequency is voiding more than every 2 hours, and this may be caused by inflammation, decreased bladder capacity, psychologic disorders, or increased fluid intake. Urinary hesitancy is a delay in starting the stream of urine, and it may be related to a partial obstruction. Urinary retention is retaining or holding urine in the bladder. There are various causes and may include neurologic, psychological, medication, obstruction, or post-surgical. Residual urine is urine that is left in the bladder after voiding. This may be related to poor muscle tone or partial obstruction. Colorless or pale yellow urine may be due to diuretics. The dilute urine because of diabetes insipidus, diabetes mellitus, overhydration, chronic renal disease, nervousness, or alcohol. Bright yellow urine is due to riboflavin from multivitamins. Dark amber to orange colored urine may be due to pyridium, macrodantin, or thiamine, and it's a concentrated urine because of dehydration or increased metabolic state. Urobilinogen, which is a byproduct of bilirubin, normally excreted through stool and urine. Bilirubin, which is a component of bile, foods, and excessive carrots. Pink to red color may be due to medications such as compazine or doxadan, dilantin, rifampicin, or cascara, senna, fresh red blood cells, menstrual contamination, myoglobulin, foods such as beets, blackberries, and red food dyes. Brown urine may be due to cascara or flagell or compazine. It's extremely concentrated urine because of dehydration or increased metabolic state due to red blood cells, bilirubin, urobilinogen. Blue or green colored urine may be due to medications like Elavil or methylene blue. It may be due to bilirubin or Pseudomonas infection. Dark brown to black urine may be due to iron, levodopa, macrodantin, quinine, melanotic tumors, Addison's disease, red blood cells like old blood, large amounts of rhubarb or aloe. Normal urine develops an ammonia-like odor after it has stood for a length of time, but this odor should not be present in freshly voided urine. When considering the assessment for urinary symptoms, we always ask the patient about pain or discomfort. See if there's any bladder pain, any flank pain, any pain with urination. With a urinary catheter, the nurse must use aseptic technique and gentle handling when caring for any urinary drainage tube. We insert the urethral catheter using sterile technique. Do not open a urinary drainage system unless there is no alternative. The drainage bag must be changed for some reason, for an example. Empty the drainage bag by opening the drainage port at the bottom of the bag. Use aseptic technique and do not allow the drainage tube to touch the collection container. After reclamping the tube, wipe away any residual urine from the tube with an antiseptic swab before securing it. We should use the patient's individual collection container for draining the urine storage bag. We need to make sure we observe all tubes and the level of drainage in the collection bag each time the patient is seen. The nurse should keep the drainage bag below the level of the catheter or the insertion site to prevent any backflow. If the bag must be raised above the insertion site, the tubing should be clamped off briefly while repositioning the patient. Perineal care should be performed at least twice daily, cleaning the urinary meatus and the catheter with soap and water, rinsing well, just as the area would be cleansed if the patient were bathing routinely. We should also keep an intake and an output record to monitor the kidney function. We should encourage fluids of 3,000 milliliters per day. When irrigating a catheter, we use the correct amount of sterile solution. We use a steady, gentle stream to irrigate, and we avoid exerting pressure that may traumatize or cause discomfort. We do not pull back forcefully on an irrigating syringe that is attached to the urinary catheter or tube. This will create a negative pressure that may damage delicate tissues or collapse the tube. When discontinuing an indwelling catheter, we never cut the catheter. We use a syringe to deflate the balloon. Urinary catheters are one of the most common causes of healthcare-associated infections. In 2011, there were 93,300 urinary tract infections in hospitalized patients, and 75% of those were catheter-related. The first step in managing incontinence is to identify factors that may be contributing to the problem. It may be immobility, UTI, atrophic urethritis or vaginitis associated with menopause, stool impaction, prostate surgery, delirium or confusion, endocrine problems, medications such as alpha adrenergic agents, beta adrenergic agonists, and calcium channel blockers. Obesity may also be a factor because it causes increased pressure on the bladder. Urge incontinence is the involuntary loss of urine when there is a strong urge to urinate. Stress incontinence occurs when the urethral sphincter fails and there is an increase in intra-abdominal pressure caused by something like sneezing, laughing, coughing, or even aerobic exercise. Mixed incontinence is a combination of different types such as stress and urge incontinence. Overflow incontinence occurs when there is poor contractility of the detrusor muscle or obstruction of the urethra, as in prostatic hypertrophy in a male, or genital prolapse or an abnormality in a female. Functional incontinence can be caused by the cognitive inability to recognize the urge to urinate or self-care deficit caused by extreme depression. The inability to reach the bathroom because of restraints, side rails, or an out-of-reach walker may also result in functional incontinence. Neurologic incontinence is due to disorders of the neurologic symptoms. Examples are multiple sclerosis or spinal cord injury. When diagnosing urinary incontinence, the nurse needs to ensure that she does a good history and physical, takes all the report of the patient's symptoms, asks the patient to keep a bladder diary, perform a routine urinalysis. We may do post-void residual stress testing, a cystogram, or a cystoscopy. Treatment for urinary incontinence. One is Kegel exercises. To locate the correct muscle, Stop the flow of urine while urinating on the toilet by tightening the anus as if it were a bowel movement. This should be practiced for several days each time the patient urinates, then begin the exercise program. While lying down, slowly count 1, 2, 3, while tightening the pelvic muscles. Release the pelvic muscles and slowly count to 1, 2, 3 again. Do this for 15 times. While sitting, repeat this sequence 15 times, tightening the pelvic floor muscles while counting and then slowly releasing to the same count. The patient should stand and repeat the sequence 15 times, tightening to the count and then releasing to the count. The pelvic floor exercises should be done daily. If the patient can do them twice a day, improvement in continence will occur more quickly. Improvement in incontinence should be noted in 6 to 8 weeks, but it may take as long as 3 months. The nurse needs to be very thoughtful when asking individuals related to urinary or bowel issues. We want to make sure that as a nurse we ask all the appropriate questions such as color, odor, how often, drink, how much they drink a day, what do they eat a day. We think about bladder training exercises, and we will also make sure that we discuss with the patient drinks to avoid and other substances that need to be avoided. Urinary retention is retaining or holding urine in the bladder. It may be acute after a surgical procedure, after removal of an indwelling catheter, or with some medications. Or it could be chronic, related to anxiety, neurologic disorders, or obstruction of urine flow. Urinary retention will not cause the bladder to rupture, but urine will begin to dribble out of the urethra. The retention of urine will stretch the bladder walls and cause extreme discomfort. The nurse needs to assess the degree of bladder distension using gentle palpation before and after the intervention of urination. We need to assist the patient by providing privacy and adequate time for voiding. A caffeinated drink followed by a warm bath may assist the patient. We instruct the patient to double void. Void, sit on the toilets for several minutes, and then void again. We will schedule a trip to the toilet every 3 to 4 hours, and if necessary, obtain an order for catheterization. A medication for urinary retention is bethanyl. Examples of medication that may relieve symptoms that are produced by benign prostatic hypertrophy or an enlarged prostate gland is Flomax or Credura.